Hello everyone, welcome to the AAA series of our program at Study Medic. I'm Dr. Tabinda and I'm the mentor for MRCPI. So we have started this series for a better revision for all of you. And the topic for today's discussion is management of second trimester miscarriage. This is the RCPI guideline, which I have chosen for discussion today. So let's start with the guideline. Okay, so first of all, what we have to remember is that never do great things come from comfort zones. So everyone has to struggle in order to achieve something, achieve their goals. So we should always take the first step towards our goal. So the management of second trimester miscarriage. First of all, the definition and the causes about it. A second trimester miscarriage, it may be defined as the pregnancy loss which occurs after the 12th and before the 24th completed week of pregnancy. And they have told us about the estimated number of miscarriages in Ireland, which is around 14,000 miscarriages per year in Ireland. And the miscarriage rate, they have told us that it has reduced to approximately 1% if the fetal heart rate is visible at the 10 weeks of gestation. And it is in low risk women, the risk of miscarriage in the second trimester is approximately 0.5%. The causes that they have described in the guideline is, first of all, they have told us about the fetal structural abnormalities. And then there can be some maternal uterine abnormalities. The maternal structural, that is the uterine structural abnormalities. So there can be, the bicornuate uterus or the didelphys or any septa that may be present in the uterine bodies. So that is one reason. Then there is the cervical insufficiency or the incompetence. And then comes the factor V laden mutation, the protein S deficiency, and the prothrombin gene mutation. And of course, the antiphospholipid antibody syndrome, it can also cause placental thrombosis. So it is also going to increase the risk of second and the third trimester losses. Then the chromosomal abnormalities, they are also important, definitely. And infection. In 10 to 25% cases, it is infection which is causing the second trimester miscarriage. So infection due to bacteria, spirochetes, protozoa, viruses, and fungi. And most important, they have mentioned that bacterial vaginosis has been associated with the second trimester pregnancy loss. So this you have to remember. The key recommendations in this guideline, first of all, the full clinical assessment has to be made when the woman comes in. And then we have to deal it with the Irish Maternity Emergency Warning System for the monitoring of all the pregnant women who are admitted to the hospital in the second trimester when they come to us. And real-time ultrasonography is used for the accurate diagnosis of miscarriage. So we are going to diagnose the miscarriage by using the ultrasound. And they may need to be repeated in selective cases. Lab investigations also they have mentioned, and we will be discussing in detail about that. And they said that if the cervix is closed, membranes are intact, a combination of mifepristone and prostaglandin should be considered as the first-line agents for induction in second trimester miscarriage. And of course, when they are previously scarred uterus, so we have to take care and half the dose of the misoprostol that is being used. And if there is any evidence of chorioamnionitis, then we should start with the broad-spectrum IV antibiotics without delay. And we are going to consider delivery irrespective of the fetal viability. Because now she has developed chorioamnionitis, so we should focus on delivery. And for pathological examination, the cord, membranes, and placenta, they should be used. And fetal cytogenetic analysis should be done for all the cases of late miscarriage. And the best tissue for this is placental tissue. The supportive care should be given to these couple because obviously they are in a sorrow state. so it is always needed. And a follow-up appointment with a senior obstetrician should be arranged for women following a second trimester miscarriage. So this is about the key recommendations that the guideline talks about. And the clinical assessment involves the history and the examination over here. In history, what is important, what happens is mostly these women come with complaint of vaginal bleeding or intermittent abdominal pains. And they may have history of ruptured membranes or some passage of pieces of conception, or they may complain of vaginal discharge, which may be offensive or it may not be. And there may be some history of infection in certain cases. And a past history of previous pregnancy loss, as well as previous history of cervical surgery may also be there. In examination, we are going to look for vital signs, and we are going to have an abdominal examination done for these patients. And if there is any tenderness, we are going to see the pulse, and if along with tenderness, and if there is also offensive discharge, so it may indicate chorioamnionitis. In the absence of ruptured membranes, a gentle vaginal examination should be performed to assess the cervix and any vaginal bleeding if present. If the cervix is dilated, then we are going to avoid the rupturing of the membranes or precipitating any sort of ascending infection. So these we have to remember the points. And if we are not sure of the membranes, if they have been ruptured or not, then we are going to do the sterile speculum examination. So the speculum has to be sterile in order to prevent any sort of infection being introduced. So pooling of amniotic fluid is evident in the posterior vaginal fornix to confirm that the membranes have been ruptured. An ultrasound also can be done, and if the ultrasound is showing oligohydramnios, it is also useful to diagnose that there has been a rupture of membranes and there has been leaking. So a normal AFI does not exclude, however, the diagnosis of ruptured membranes, and a swab should be sent for culture sensitivity if the vaginal discharge is present. A vaginal examination with ruptured membranes should be deferred until induction. So that is what they have told us. Investigations. First of all, obviously, we have to do the ultrasound examination. We are going to look for the fetal heart. Of course, if it is not there, then that is going to confirm the miscarriage. Then the presentation is also important because we are going to induce the lady, and so the presentation matters. And we are going to see the liquor volume and the placenta where it is localized. And for this ultrasound, a trained ultrasonographer may be required to confirm the fetal demise or any sort of structural abnormality in the fetus as well. In lab tests, full blood count should be done. And in pregnancy, they say that an allowance should be made for the increase in the white cell count because of the pregnancy. So the white cells are slightly increased in the during the pregnancy. Maternal coagulation testing should be done, and blood group and antibody screening also should be done. Kleihor-Betke test is also important, and irrespective of resuscitate status, a Kleihor-Betke test is done to detect the feto-maternal hemorrhage. And C-reactive protein is also, if infection is suspected, then we'll do the C-reactive protein, and the role of inflammatory markers is uncertain. So that it is not of very much importance that they are saying, but in combination with all the other tests, this can be also done. Maternal microbiology. In maternal microbiology, we are going to do the maternal blood cultures if needed, and midstream urine analysis, vaginal and cervical swabs, and RFTs and LFTs should be done. Abnormal LFTs indicate possible antiphospholipid antibody syndrome, and abnormal LFTs, they have been associated with acute fatty liver of the pregnancy and with the HELP syndrome. So these are two findings that they have mentioned over here. About the cervical cerclage, they say that it is having poor outcome if the following predictors are there. And what are these predictors? If the membranes have been prolapsed, if there is evidence of intraamniotic or systemic infection, and if there is a symptomatic presentation of the patient with a cervical dilatation which is more than 3 centimeters. So, and cervical cerclage which has been applied after 22 weeks of gestation. So all these are poor predictors for the success of cervical cerclage. And about delivery, if the woman is alone, first of all, when she comes to the maternity service, we have to see that if she is alone, we are going to counsel her to summon some personal support. So whoever is along with the woman, we will ask the woman to bring them along so that this news is not actually something very, it's not good. It is an emotional feeling that she's going to face. So it's better to call the attendants, whoever is along with her. Management should be discussed in detail. Await a spontaneous miscarriage, or we can plan an induction for her. So we are going to plan whatever is in the plan, we are going to document it and discuss it in detail with the couple. In sepsis, in fulminating preeclampsia or massive placental abruption, in all these cases, we are going to expedite the delivery. An individual midwife or nurse should be assigned to the woman. And if the woman is admitted to the hospital, then the ideal setting is a ward where there are no women with uncomplicated pregnancies or healthy babies, so that she is isolated. She does not have to see any babies or pregnant women, and so as to relax the patient. Review medically and discuss the care plan with the couple, and pastoral care should be offered also. And we are going to look for any evidence of deterioration in her vital signs. So she is going to be monitored continuously with the IMUS system. And what is the risk of infection in the second trimester miscarriage? In women who have miscarried, the cervix may remain closed and the amniotic sac may remain intact. If there is no intervention done, then the risk of ascending intrauterine infection is low. So, in women where the os is dilated and the membranes have been ruptured, or where the amniotic sac or its contents are protruding through the cervix, then there the risk of ascending intrauterine infection is increased. A vaginal swab should be sent for culture and sensitivity. And if an infection is suspected, appropriate doses of IV antibiotics should be administered as soon as possible. And if fetal demise has already occurred and the woman is hemodynamically stable, then arrangement should be made to induce the delivery. And comes the management for the second trimester miscarriage. There can be 3 managements. One is the expectant, the other one is medical, and the surgical. So expectant management, in expectant management, more than 85% of the women with an IUFT will deliver spontaneously within 3 weeks of the diagnosis. 10% chance is there of maternal coagulopathy 4 weeks from the date of fetal death. So these are important percentages. Rarely do they ask in exam about the percentage, but they are very common. So you can remember this. In medical management, the combination of mifepristone and prostaglandin is recommended as a first line. This combination is safe and with an average time to delivery interval. So it's going to decrease the time taken from the induction time to delivery time. A single 200 mg dose of mifepristone is appropriate for the induction after the IUFT. And the advantages about the misoprostol, they have mentioned, it is low cost, long shelf life, there is lack of need for refrigeration, and worldwide availability. So it is cheap and it is easily available, and there is no storage considerations about it. So its effects are dose dependent, and it includes the cervical softening and dilatation, uterine contractions, nausea, vomiting, diarrhea, fever, and chills. So these are the effects of misoprostol. Comparing the vaginal, sublingual, and oral routes, sublingual misoprostol has the shortest induction to expulsion interval, but it has more side effects. The sublingual route we are talking about. If the cervix is closed, then and membranes are intact, then vaginal misoprostol recommended in view of lower side effect profile. From 13 to 17 weeks of gestation, vaginal misoprostol is recommended, and the dose is 200 micrograms 6 hourly, up to 4 doses maximum. And from 18 to 24 weeks, the dose of misoprostol, which is recommended, is 100 microgram, which is half a tablet, 6 hourly, and maximum 4 doses are allowed. So women with a scarred uterus, we already know that they should receive half the dose, which is recommended. If doctor wishes to avoid the use of vaginal misoprostol, then oral misoprostol or IV oxytocin may be considered as well. Active management of the third stage should be performed once the cord is clamped. And if the third stage is not completed within 1 hour, then manual removal of the placenta in theatre should be considered. So just remember the doses. From 13 to 17 weeks, it is vaginal misoprostol 200 micrograms 6 hourly, 4 doses. And from 18 to 24 weeks, it is 100 micrograms 6 hourly, 4 doses. Now coming to the surgical management, it may be necessary for women with persistent excessive bleeding. So as to minimize the blood loss and save the patient, we have to perform the surgery. And if the patient is hemodynamically unstable, then we have to perform. And evidence of infected retained tissue is there then also. And if there is any suspected gestational trophoblastic disease. We are going to take informed written consent for risk of uterine perforation, cervical tears, intra-abdominal trauma, hemorrhage, and infection. So a written consent is always a necessary. Analgesia, all usual modalities should be available, including regional anesthesia and patient-controlled anesthesia. Regional anesthesia may be required and should be an option for women. And assessment for maternal coagulopathy and sepsis may also be an option required, regional anesthesia. In postnatal care, we are going to offer the couple to hold their baby, whatever the gestation it was. And the staff should also make the couple aware that the gender is not always easily identified. So if the fetal gender should not be assigned, and confirmation of the gender may be available through cytogenetics or postmortem examination, that we have to tell them. And the couple may decide on a neutral name on naming their baby, as these results may take a number of weeks to be known. Ideally, the couple should be allocated a separate room on their own after the delivery with open visiting. And also, they will be referred to a member of the bereavement team or a spiritual advisor of whatever they choose, whoever they choose, and a medical social worker. On postnatal investigations, which are recommended, they include serology for cytomegalovirus, toxoplasmosis, parvovirus, rubella, and syphilis. In case of positive tests, infectious disease specialists should be consulted. Then the thyroid function tests and investigation for thrombophilia, which includes the anticardiolipin antibodies, the lupus anticoagulant, and the activated protein C resistant, and parental karyotyping, which may also be indicated if a fetal balance translocation is identified. So at first, we are going to do the fetal karyotyping, and then if any balance translocation is identified in the fetus, then we will do the parental karyotyping. Maternal autoantibody testing may also be required, and maternal toxicology. Pathological examination. First of all, there is the external examination. A perinatal pathologist, neonatologist, or a pediatrician may need to perform a detailed external examination of the baby. Analysis of the placenta, the cord, and membranes. Pathological examination of all of these three is recommended, whether or not post-mortem examination of the baby is requested. So this should be done whether or not the examination is requested, this should be done. Post-mortem examination provides more information than other tests. Attempts to pressurize the couple to choose a post-mortem examination should be avoided. Individual cultural and religious beliefs must be respected. Non-sensitized, rhesus-negative women should receive prophylactic anti-D immunoglobulin. Thromboprophylaxis, according to the national guidelines, they should be followed, but miscarriage alone is not a risk factor on its own. In supportive care, couples' individual needs should be identified and accommodated, and every assistance should be given to facilitate the grieving process, including appropriate literature and contact phone numbers that we are going to provide them. The couple should be offered to have pictures taken, if appropriate, and or hand footprints can be taken of the baby. These can be left in the medical chart for a later date if the couple do not wish to take home immediately, so they can collect it later on. And we should give information regarding the burial and the cremation. About the discharge, the woman should be reviewed by an obstetrician before discharge, and a written information on supportive care should be given to them. Any existing antenatal appointments should be cancelled so that reminders are not sent to them, because what happens is that they get phone calls from the hospitals that you have an appointment, so please visit on so and so date. So these appointments should always be cancelled before their discharge so that they are not called. A telephone call should be made to the family doctor and public health nurse as soon as possible after the diagnosis of a second trimester miscarriage. And about the follow-up appointment should be made with the consultant, and the results of the investigations should be available at the follow-up visit. Subsequent clinic appointments should ideally take place in a quiet and undisturbed location within the hospital. So this is all about the management of the second trimester miscarriage. Hope it was helpful to all of you. Thank you very much. And do subscribe to the YouTube channel and click on the bell icon to keep updated. Thank you so much.